Yes, we can start now, please. The the incidence and pattern, risk factor and outcome of the retinopathy of prematurity in North Karnataka. Chief author is Sandeep Patil. Presenting author Dr. Ishan Goyal. Yes, you can start.
Uh, Good evening, everyone. Thank you, APAO AIOS, for this opportunity. The title of my presentation is the Incidence, Patterns, Risk Factors, and Outcomes of Retinopathy of Prematurity in North Karnataka. Now, ROP is one of the most widely recognized causes of visual impairment in preterm babies. In emerging economies like India, we are undergoing the third epidemic of ROP. Now, a lot of studies have been done around in babies of around 1700 grams, but very less studies are available for babies up to 2 kgs. So now these babies would have been missed by American and British guidelines. So it is very much necessary that we stick to Indian guidelines as per RBSK. So our research objectives were to find out the incidence, clinical profile of these infants, and study the patterns of ROP and outcomes of infants in these babies. So it was a prospective study from 2023, April 2023 to March 2024, and patients were screened as per RBSK guidelines. Each baby underwent wide field digital imaging, and baseline characteristics were noted as per ICROP3. Staging and zone were defined. So if it was an immature retina, we followed it up till it was mature. If ROP was present, then we managed according to ETROP study guidelines. Now, the results of the study. Our we had 170 infants, 340 eyes of 170 infants. 63 eyes of 33 infants were ROP positive. That means actually 3 babies, only 1 eye had ROP changes, and 2 infants had type 1 ROP changes, that is treatment requiring, while other eye had type 2 ROP changes. So the incidence rate came out to be around 18%. And around 22 eyes out of the affected eyes had type 1 ROP, and 41 eyes had type 2 ROP, that is non-treatment requiring. But we had a staggering rate of 22% aggressive ROP changes, and that is very significant in a study. So these are some of the result images using our own digital wide field imaging system. This one shows stage 1 zone 3 ROP, the second image shows stage 2 ROP. This is a stage 3 with extraretinal neovascularization, and this is a partial retinal detachment not involving the macula, stage 4 ROP. These are pre-plus diseases, and this is a plus disease showing a lot of tortuosity in the posterior pole. And these are aggressive ROP showing flat neovascularization and hemorrhages, mainly confined to the posterior pole. And these are some of the post-treatment laser images. So significant association of ROP was noted with cardiorespiratory support, oxygen therapy, septicemia, apnea, anemia, and low gestation age and birth weight. Coming to the discussion part, our study showed 18% incidence of ROP, which is comparable to around 20 to 40% reported in various studies done across regions in India. Our study shows 35% babies had type 1 ROP, that is treatment requiring, compared to 9.9% in a study done in a neighboring district by Bhatt et al. Aggressive ROP was very high in our study, that is around 22.22%. This is again very high compared to Hungi et al. Gestational age, now what was staggering in our study, and that is what I mentioned in need for study, that 8 babies with birth weight more than 2 kgs and gestational age more than 34 weeks, which is generally what we keep as cutoff, had ROP. Now, these babies would have been easily missed by other guidelines. So, we need to screen because variable level of neonatal care is generally seen. So, these are my references. Thank you.
Very nice presentation. Why you have noticed 35% of incidences in your cases as compared to others?
So 35% were treatment requiring. Of 35% of the total ROP babies were treatment requiring. Others were non-treatment requiring, which regressed with follow-up.
Okay.
18% is the incidence rate, sir.
What were the risk factors in your study?
The major risk factors were oxygen, respiratory distress syndrome, ma'am, cardiorespiratory support, and anemia, septicemia, and intraventricular hemorrhage. There are a list of other this thing. Just for the sake of this presentation, a few I have listed which were significantly associated, ma'am.
So what was the most significant? Because your paper mentions as risk factors in your title. So what were your...
Most significant was oxygen therapy, respiratory distress syndrome, and cardiorespiratory support, ma'am.
And the prematurity?
Prematurity, statistically it came out to be insignificant because 8 babies more than 34 weeks still had ROP changes. So statistically, although it was insignificant, but yeah, most of the babies other than the 8 babies were less than 34 weeks. So it is a significant factor, but statistically p-value was more than 0.05.
Ma'am, you want to?
Any relationship with the stay in the NICU?
Yes, ma'am. In the paper that we are coming out, we have included that. So increased NICU stay is significantly associated with the ROP development.
Because this is one of the important risk factors.
Yes,
Because
ma'am.
since
So-
you have mentioned a risk factor,
Yes,
and stay in the NICU is one of the most important risks, whatever the etiology is.
Yes, ma'am.
Okay.
Because of mainly oxygen dependence, more oxygen dependence.
Not
as
only
with this,
oxygen
ma'am.
dependence, the septicemia,
Septicemia,
and
yes,
all
ma'am.
comorbidities.
Yes, yes, ma'am. Thank you.
Second speaker, Dr. Ashriya Karpe. Will be speaking on pigmented paravenous chorioretinal atrophy, a case of mistaken identity. You are Dr. Ashriya Karpe?
No, sir. Dr. Shivangi. I've been marked absent apparently. They were saying by the
Doctor,
Shivangi.
where is you? This one, yeah, we had taken the attendance, that's fine. Second last here, she's just come back. Shivangi,
Good evening, judges, and thank you to the organizers for giving me this opportunity. I apologize for the layout because of some miscommunication. The poster was uploaded in a poster format instead of a PowerPoint presentation. So today I'll be talking about a case of a pigmented paravenous chorioretinal atrophy, a case of mistaken identity. So we saw a 47-year-old male patient who presented with decreased vision in the right eye since 9 months, systemically quite well. He gives a past history of being diagnosed as serpiginous choroiditis and was treated for tuberculosis with anti-tubercular treatment for the last 8 months. On examination, the anterior chamber was quiet. Visual acuity was 612 in the right eye and 6.6 in the left eye, with a posterior subcapsular cataract, which was not very significant. Fundus examination showed a clear, uninflamed vitreous. The disc was normal, well perfused. There was pigment accumulation along the venules in an arborizing fashion, and retinal pigment epithelial changes were seen along the distributions of the venules and around the optic nerve head. The macular reflex was dull. So when we did an autofluorescence imaging, that revealed hypoautofluorescent patches along the retinal veins, which suggested retinal pigment atrophy. The OCT examination revealed retinal epithelial thinning and an epiretinal membrane in both the eyes with a lamellar macular hole in the left eye. So coming to the discussion, PPCRA is an uncommon form of chorioretinal atrophy which was first described in 1937 by T.H. Brown and was called as retinochoroiditis radiata. Although the exact etiology is not known, but inflammatory causes have been mainly identified, and in such cases, it's then described as a pseudo-PPCRA. The patients are usually asymptomatic and they're diagnosed during a routine examination. It's a non-progressive condition, but the following DDs can be described. Pericentral or sectoral or typical RP, helicoid peripapillary chorioretinal atrophy, most commonly serpiginous choroiditis, autoimmune retinopathy, HCQS retinopathy, toxoplasmosis, syphilis, sarcoidosis, gyrate atrophy, choroideremia, tuberculous choroiditis, cone dystrophy, and angioid streaks. Depending on the distribution of the pigment, PPCRA can be classified as paravenous, focal, or confluent. Paravenous means along the veins, focal where there are isolated chorioretinal atrophy patches with pigment clumping, and confluent is where the chorioretinal atrophy along with the pigment, they extensively merge with one another, and the case is often misdiagnosed as a retinitis pigmentosa. The fundus autofluorescence shows a continuous hypoautofluorescence along the retinal veins, suggestive of atrophy with pigment accumulation. To conclude, although it is often associated with inflammatory conditions, this is often misdiagnosed as serpiginous choroiditis and treated with anti-tubercular treatment. Therefore, it's very important to differentiate this from an inflammatory condition rather than subject the patient to intense autoimmune and systemic therapy, as compared to this condition, which is non-progressive, and the patient usually remains stable. Thank you.
So, what are the main differentiating point between this PPCRA and your serpiginous choroiditis?
So, most commonly is patient did not give any history of any vision loss ever. He had no systemic conditions. There was no inflammation. The vitreous was clear. And serpiginous choroiditis usually is associated with recurrent episodes. So, he had no such history. But he was misdiagnosed and treated as a serpiginous choroiditis.
So, basically, it is a non-progressive.
It is a non-progressive and it's quite benign. Patients usually remain stable unless they develop a cataract or some other epiretinal membrane.
Right.
Do you have a history? What treatment did he receive before he came to you?
No, ma'am. He did not have any record of what exact antitubercular treatment he had received, but he did say that he was due to complete the entire course.
Any anti-inflammatory given during that time?
No, ma'am. It's just ATT and some topical steroids, but no systemic anti-inflammatory treatment.
The rationale of starting ATT, was the patient getting any records,
Ma'am,
Mantoux or anything?
Ma'am, it was started elsewhere. We didn't
So
start
the patient
ATT.
was not having any records?
No. The
Any dye test which you have done?
The patient was coming from a regional, a small place. So
Any
he did
dye
not have.
test which you have done? Any
Sorry?
fluorescein angiography, and ICG or OCT?
In the previous.
Is in this patient mein?
In this patient, we did do autofluorescence, we did do OCT.
Huh.
There was no indication of doing a fluorescein angiography because autofluorescence did not show any active patches which are seen in choroiditis. So we did not do a fluorescein angiography. Ma'am.
Thank you. We'll go to the third speaker, Dr. Anushri Naidu. You'll be speaking on anterior segment migration of the Ozurdex implant through the surgical PI.
Good afternoon, everyone. Today I'll be speaking on anterior segment migration of Ozurdex implant through surgical PI, a rare complication. Ozurdex is a biodegradable dexamethasone implant that uses Novadu drug delivery technology, in which the biodegradable material is paired with an active drug. Intravitreal injection of Ozurdex is routinely used for the treatment of cystoid macular edema associated with epiretinal membrane diabetic retinopathy and intraocular inflammation. Anterior segment migration of intravitreal Ozurdex implant is a rare complication and it is reported in 0.63 to 1.6% cases. It leads to complications like secondary corneal decompensation and refractory corneal edema. In patients with incipient corneal edema, urgent removal of Ozurdex is mandatory. 65-year-old female presented to us 2 years ago with a history of nucleus drop during cataract surgery done elsewhere. We managed the patient with pars plana vitrectomy, phacofragmentation, and a SFIL was implanted. Patient gained a best corrected visual acuity of 6/18 and 10 2 months post-operatively. However, 6 months after the surgery, the patient came to us with decreased vision, and on examination, we found that she had developed an ERM with CME. Her BCVA noted that time was 6/60. We started the patient on conservative medication with topical and oral steroids, and the patient showed improvement in the 1 month period after the starting of conservative treatment, and also the vision had improved. We continued the conservative treatment. The neurosensory detachment had resolved completely, but the CME persisted in 2 months post-operative period. After waiting for 3 months, there was a refractory CME and the CME had increased again. Then we decided to inject the patient with Ozurdex implant and the patient underwent the same. However, 3 weeks post the injection, the patient presented to us with diminution of vision and a BCVA of counting finger 2 meter. The slit lamp examination revealed the anterior segment migration of Ozurdex with the corneal stromal edema. This is the image of ASOCT showing the CCT of 887 microns, and this is an ASOCT image through which the section is showing Ozurdex in the anterior segment. An immediate explantation of Ozurdex was done, and we decided to observe the patient for corneal edema. Corneal edema was managed initially conservatively with topical and oral steroid cycloplegics and topical hyperosmotic agents. The edema persisted for 2 months even after the conservative treatment. However, the CME had resolved completely. After the 2 months, we registered the patient for DMEC. After a waiting period of 3 months, the patient ultimately underwent DMEC. And the slit lamp photo, this is showing 1 week after the DMEC surgery, and patient had gained a 6/24 and 12 vision by then. At 2 months post op, the patient gained a 6/12 and 10 vision with ASOCT showing normal cornea and thickness CCT of 522 microns. The OCT macula showed complete resolution of CME that was present even then. Anterior segment migration of intravitreal Ozurdex is a very rare complication. Corneal decompensation is the dreaded outcome of the same. Prompt removal of Ozurdex is the key to prevent corneal decompensation. And in our case, despite early removal, the patient had a corneal decompensation and ultimately required treatment. With appropriate management, ultimately the patient gained a BCVA of 6/12 and N10. To conclude, I would like to say that in cases of ERM with CME in vitrectomized eye, which is resistant, Ozurdex remains the treatment of choice for management. However, the caution should be taken regarding the anterior segment status, any large surgical PIs, any posterior capsular length, or any zonular weaknesses in such patients while administering the same. Thank you.
Why this implant was gone into the anterior chamber? What are the mistake that has committed?
Sir, actually the PI was slightly centrally located. It was a large surgical PI, and when the implant slightly reduced in size, it migrated through the anterior segment. And apart from that, it was an SFIL patient with no posterior capsular support, and hence there was a higher chance of such complications occurring.
So the corneal decompression was very much in this case.
Yes.
That's why.
Yeah, it was like present at the presentation. The patient actually presented to us 2 days after she experienced DOV, and by that time the corneal edema had increased a lot.
What was the reason for waiting for 3 months for DMAC?
Sir, initially we tried managing with the conservative management, and the cornea also, suitable cornea was also not available during that time for the transplantation. And we decided to manage the patient conservatively. She was improving slightly. We were waiting for it to subside on its own, but it was not happening, and that's why in the end we took the patient for DMEC.
What about the intraocular pressures?
The intraocular pressure were stable throughout initially. After the DMEC, the patient had experienced a rise in IOP, but it was managed very well with topical and oral agents or drugs, and the patient remains stable. Now the IOP is stable.
How long you have followed this patient, and what was the last visual recovery?
So the complete visual recovery last was 6/12 and N10. The patient has been followed up now for 4 months after the DMEC surgery. The total duration of follow-up of the patient from the beginning is around 2.5 years.
Now, in an eye in which can I?
Yeah.
In an eye which has undergone a vitrectomy, which is better, intravitreal triamcinolone or Ozurdex?
Ma'am, both the options are there, but
one is better, definitely.
Yeah,
I'm giving you
triamcinolone is safer in the way that it won't come into like this, but then it can also come into the anterior segment. And the other thing is that it won't be there for a longer time in a vitrectomized eye. So Ozurdex will stay for a longer duration, and hence the profile that efficacy would be there.
In case of triamcinolone, the secondary glaucoma is more common rather than Ozurdex.
Because it will migrate and it can cause the blockage of the meshwork also.
Thank you. Next call.
Right, so we can have the fourth speaker, Dr. Kiran Vaidya. She'll be speaking on comparative study on efficacy of intravitreal brolucizumab versus aflibercept in diabetic macular edema.
So as we know, DME is defined as the accumulation of fluid in the intraretinal and subretinal layers of the retina. Aflibercept with molecular weight of 115 kilodaltons binds with VEGF-A, B, and placental growth factor. Brolucizumab with a molecular weight of 26 kilodaltons binds with VEGF-A and in a 2:1 ratio. The aim of my study was to compare the changes in visual acuity and central macular thickness after injection of aflibercept and brolucizumab in treatment-naive DME patients. Objectives were to study the change in visual acuity and central macular thickness and to study if either drug is superior to the other in terms of clinical or anatomical improvements. So it was a single-centered randomized prospective comparative study carried out in Department of Ophthalmology at B.R. Singh Hospital for 18 months in 124 eyes. Patients with diabetic retinopathy and macular edema with central macular thickness of 300 microns on OCT were included in the study. Patients with infections, intraocular inflammations, glaucoma, or having received prior intravitreal injections for retinal vascular or degenerative diseases were excluded. Baseline investigations were carried out and then they were followed up every 6 weeks up to 52 weeks. The study group was divided into Group A, which received aflibercept, and Group B, which received brolucizumab. They were given 5 initial loading doses at every 6 weekly intervals, after which at 30 weeks, a disease activity assessment was done. If there was increase in activity, then the injections were again given at 6 weekly intervals. If there was no increase in disease activity, the injections were now given at 12 weekly intervals. So again at 52 weeks, disease activity assessment was done. We found that mean BCVA improved significantly in both groups, but there was no statistical difference. Also, mean CMT improved significantly in both groups with no statistical significance. But the percentage of patients with central macular thickness less than 280 microns in aflibercept group was 28% at 30 weeks and 43% at 52 weeks. And with brolucizumab, it was 47% at 30 weeks and 59% at 52 weeks. The percentage of patients without subretinal and intraretinal fluid with aflibercept was 17% at 30 weeks and 34% at 52 weeks. And with brolucizumab, it was 30% at 30 weeks and 48% at 52 weeks. There were no severe adverse reactions. So the Kingfisher study also concluded that there is no clinically meaningful difference in visual outcomes between brolucizumab and aflibercept, but brolucizumab was slightly superior to aflibercept in terms of reducing SRF and IRF. In this study also, we found that BCVA improved significantly, along with CMT also decreasing significantly in both groups. In aflibercept, 34% eyes and brolucizumab 48% eyes showed absence of SRF and IRF. Aflibercept showed 43% and brolucizumab showed 59% eyes with reduction of CMT less than 280 microns at 52 weeks. So in conclusion, the efficacy of brolucizumab and aflibercept were comparable in terms of both visual acuity improvement and CMT reduction in treatment-naive DME patients. But brolucizumab showed slightly higher results in SRF and IRF reduction. Thank you.
So in your study, brolucizumab is better molecule than that one.
Yes, in terms of anatomical, it is slightly better.
And clinically, as far as central macular thickness is concerned?
It is comparative to aflibercept.
And the cost-wise, price-wise?
So price-wise, brolucizumab would, for cost-effective, yes,
Yeah.
for patients, yes.
So were your patients paying patients or were they covered under insurance?
Oh, they were actually government employees, actually, central government employees.
Railway is providing the molecule.
How the patients were divided into 2 groups? Was the rationale, were they randomized or just
It was simple random sampling.
simple random
Yes, ma'am.
sample? Baseline characteristics, they were comparative or there was any difference in the thickness and all those?
Yeah, so,
parameters, because they have not been mentioned.
yeah, so
If
baseline
one
investigations.
of the group might be having less thickness. The other, those baseline parameters, were they compared?
हाँ ma'am, the baseline characteristics basically all patients above 300 micron CMT in both groups. They had more than 300 micron CMT.
Might be having 500, the other 600, the one 300.
Yeah, ma'am.
So baseline parameters.
Yeah, it
Because
was.
you are young an ophthalmologist, before we start any study, the baseline parameters have to be compared before we proceed.
Okay, thank you.
Next, we have Dr. Latika Vasu. She'll be talking about normative data and determinants of GC-IPL thickness in South Indian adults.
Oh, you're the last one? Yeah.
Good evening, respected judges and dear colleagues. So we already know that GCIPL thinning can indicate neurological diseases, but this study is regarding what is unclear. Basically, what is the normal GCIPL thickness in Indian adults? The current evidence is at best variable. And what are its determinants? Are there any modifiable lifestyle-related factors that could actually prompt prevention of retinal neurodegeneration by appropriate lifestyle interventions? That was that was the reason why we designed this study, and it was a cross-sectional hospital-based study in a tertiary care hospital over a period of 18 months, done in adults who had best corrected visual acuity of 20 by 20. 168 was our sample, and any problem that could affect the retinal architecture of the ganglion cells or the retinal nerve fiber layers were excluded from this study. So using a questionnaire, we assessed the demographic data and history regarding diabetes, hypertension, smoking, alcoholism, digital screen time, and a thorough ocular examination was done, followed by an OCT to measure the GCIPL thickness. So coming to the results, in our study, the GCIPL thickness, the normative data was found to be 79.49 plus or minus 6.37, with females having thinner GCIPL compared to males. And the thickness also decreases with age by 0.151 microns per decade. We also looked into the influence of diabetes and hypertension and found that in both these diseases, even without retinopathy, the GCIPL were thinner in both these groups. The digital screen time, to our surprise, it came up that people with more than 10 hours of digital screen time had a thin GCIPL. Smoking and alcohol consumption did show up a thinner GCIPL, but not statistically significant, whereas to our surprise again, caffeine, that is coffee more than 3 cups per day, showed up a thinner GCIPL thickness. So coming to the comparison with other studies, this normative data was actually lesser than other studies from India and abroad, and this could be due to the geographic or ethnic diversity as well as differences in the inclusion criteria, and most of the other existing evidence concurs with our relationship, our determinants of age, diabetes, and hypertension of GCIPL, but there were absolutely no studies comparing it with digital screen time and caffeine. So age, female, sex, diabetes, hypertension, and digital screen time were producing thinness, or were producing a GCIPL thickness of less. These were the determinants of GCIPL thickness in the Indian population. And what this study actually adds is that it provides a reliable reference for normative data of South Indian population, and it also proves that retinal neurodegeneration, as evidenced by GCIPL thinning, preceded fundus and OCT signs of retinal microvasculopathy, which has great implications in retinopathy screening. And to our knowledge, this is the first study in which digital screen time and caffeine have emerged as possible modifiable determinants of retinal neurodegeneration, and this is especially relevant in today's smart work culture and lifestyle. So in conclusion, diabetes strikes the ganglion cells of the retina first rather than any other cell, and coffee plus computers could very well be a wrong combo for the retina. We are not suggesting that it is, but this raises concerns, and this is probably a first spark towards further exploratory and prospective longitudinal studies on this subject. Thank you.
What about glaucoma? That has been ruled out?
Yes,
That-
it was exclusion criteria.
That was one
Yeah,
of the exclusion
we
criteria.
excluded
Open
glaucoma.
angle glaucoma is frequently associated with
Exactly.
diabetes.
Yes, and not only that, glaucoma can produce RNFL changes and
definitely it
ganglion
is.
cell changes, so we excluded that.
What
Is-
about the sorry, sir.
Yeah, carry on.
What about the refractive errors?
Yeah.
Myopia and hypermetropia, they were आपने mention
Yeah,
नहीं किया शायद.
extremes of refractive errors were excluded. Plus 5, there was a refractive margin. We only took up. Can I have that slide once again?
No, if you mention it,
Yeah.
maybe I've missed it.
Yeah,
Huh.
we only took people who were actually having best corrected visual acuity of 6/6 in both eyes and having refractive errors between +5 to -5.
Okay.
The extremes were excluded.
And patients, those who are having diabetes along with the alcohol consumptions, what are the changes?
Yes, actually, in patients with diabetes, there was definite thinning. And alcohol and smoking, there was thinning, but it was not statistically significant when we did a multivariate analysis. That is both diabetes and alcohol. Then that statistical significance was not there, though it was thin compared to normal.
But it has been found if a patient is alcoholic or having tobacco, so the severity of the diabetic retinopathy that increases in these patients.
Yes, in alcohol patients.
Yeah.
Yes. So probably because alcohol is also inducing some sort of neurodegeneration, it is having a additive effect. I don't know. I mean, in our patients, we didn't find statistical significance, but definitely this alcohol was producing a thinning.
Okay, fine. Thank you.
Thank you, sir.
We'll have the next speaker, Dr. Mihika Dubey. You're speaking on effect of metabolic control on ganglion cell layer in diabetic patients with normal vision.
Good afternoon, everyone. Myself, Dr. Mihika, and my topic is evaluation of macular ganglion cell layer in diabetic eyes with normal visual acuity, impact of metabolic control. As we all know, diabetic retinopathy is the most common microvascular complication of diabetes mellitus. The pathogenesis of diabetic retinopathy is strongly related to metabolic factors like degree of glycemic control and hyperlipidemia. HbA1c is regarded as the gold standard indicator for glycemic control in diabetes and has been extensively studied for its impact on DR and CMT and the outer retinal layers. However, the literature lacks an evaluation of inner retinal layers in this perspective of metabolic control, particularly the ganglion cell inner plexiform layer, GCL-IPL layer. This study aims to evaluate the relationship between metabolic control, HbA1c and serum lipid levels and the GCL-IPL thickness in diabetic eyes without vision-threatening DR. It was a single center cross-sectional observation study done on 86 eyes of 43 patients on the hospital-based study in central India. All patients of type 2 diabetes with normal visual acuity 20/20 were included. Patients with other ocular diseases were excluded. Patients with proliferative diabetic retinopathy were excluded from the study. Any other surgical intervention patients were excluded from the study. Duration of diabetes was taken into account. Detailed serum lipid analysis was done. HbA1c values were recorded. Refraction was done and patients with normal visual acuity were included. OCT ganglion cell analysis was done using macular cube scan and color coding for various sectors were noted for each eye. Results were as follows. A mean age of our patients was 54 years, duration of diabetes around 8 years, HbA1c was 8.7. The mean GCL-IPS thickness in our study was found to be 79.23 microns. Out of 43 patients, 27 patients had deranged lipid levels and 16 did not. 50 eyes showed no retinopathy and 36 were with NPDR. Out of all the patients, in 7 eyes, there were abnormal average values of GCL-IPL, and in 24 eyes, the average was normal, but at least one sector of GCL-IPL thinning was noted. On statistical analysis, there was significant relation of GCL-IPL thickness with age, decreasing with age, and central macular thickness, but not with any other variable, including metabolic control. We could not find any significant impact of retinopathy on GCL-IPL thickness. But on regression analysis for sectoral GCL IPL thinning, it showed high adjusted odds ratio for HDL cholesterol, for total cholesterol, deranged total cholesterol, and deranged HbA1c, although with large confidence intervals. There have been various studies in literature correlating GCL IPL thickness with diabetic retinopathy and normalize, but along with metabolic control have not been studied. To conclude, there is a possible association of GCL IPL thinning with metabolic control in diabetic individuals. All future analysis of macular ganglion cell layer should account for inherent confounders like age and center macular thickness. And the further studies we recommend to assess impact of metabolic control on inner retinal layers along with multifocal ERG and microperimetry. Thank you.
So there is no any significant correlation between these two, metabolic control and that.
Yes, they were in calculating deranged HDL and HbA1c shows high odds ratio, but the result was not statistically significant. The trend was there. The patient with deranged HDL and HbA1c had GCL IPL thinning in sectoral GCL IPL analysis, but it was not statistically significant according to our confidence interval of p-value.
With normal vision, what about the retinopathy, stage of retinopathy?
We divided the patients with no DR and NPDR. We did not further classified into the grades of NPDR. And there was no relationship
because severe NPDR as compared to mild, moderate, it has some.
We did not study that in our study.
Okay.
Thank you.
Thank you.
So we'll have the next speaker, Dr. Dhanashri Ratra. You'll be speaking on evidence of retinal neurodegeneration in pre-diabetic stage.
Chairpersons and audience, good evening. I am going to talk to you about evidence of retinal neurodegeneration in pre-diabetes stage. With the advent of OCT angiography, the macrophage-like cells have been shown in the vitreoretinal interface, and these have been characterized as retinal microglia, which you know as self-renewing, relatively long-lived innate immune cells which exist in all the layers of the retina. Now, microglial activation is a common hallmark of many retinal diseases, and the research in animal models have shown that these microglia, which are pro-survival, when they get activated, they release a lot of cytokines which are neurotoxic. And the opportunity to visualize these cells in vivo gives us a unique, invaluable insights into the pathogenesis of the retinal diseases. Already studies in diabetic retinopathy have shown that the MLCs show correlation with the severity of diabetic retinopathy. But we know that a state of pre-diabetes exists much before the diabetes and before diabetic retinopathy. So about 15 to 20 years before diabetic retinopathy, we have a stage of pre-diabetes, and we wanted to explore these macrophage-like cells in the pre-diabetes. So this retrospective pilot study, we explored the correlation between macrophage-like cells, multifocal ERG, and structural retinal parameters in pre-diabetes. So the methods we collected, we used a strict diagnostic criteria for evaluating subjects with pre-diabetes. They underwent fasting plasma glucose, oral glucose tolerance test, and HbA1c. And we used the criteria by the American Diabetic Association and classified them as pre-diabetes. All the subjects underwent detailed ophthalmic evaluation, including vision, fundus examination, photography, OCT angiography using SD-OCT, and multifocal ERG according to the ISCEV standards. These are the exclusion criteria, and specifically we excluded patients with any other disorders or neurodegenerative disorders. So in vivo visualization and extraction of the MLCs, we used the Zeiss Cirrus 6000 machine, and 6x6 millimeter scan centered on the fovea with good signal strength was selected, and manual segmentation was done in the vitreoretinal interface using a 3 micron slab above the internal limiting membrane, and then the on-fast image was exported to ImageJ for further analysis. A stepwise semi-automated binarization protocol was done to extract the MLCs, and the extracted MLCs were then colored into red color, and they were is superimposed on the angiography image for better localization and topographic mapping. So results, we had about 60 eyes in each group. The pre-diabetic patients had a higher HbA1c level. The visual function in both the groups was normal, but there was a significant reduction of central foveal thickness in the pre-diabetic eyes. We know that hyperglycemia is a cause for apoptosis, and the cells of the inner retina are especially susceptible to hypoglycemia, and thus the reduced central foveal thickness is an indication of early neurodegeneration. There was no significant difference in the ganglion cell layer or the retinal nerve fiber layer in both the groups. However, there was a significant reduction in the multifocal ERG amplitudes in the pre-diabetics eyes in all the rings. So multifocal ERG is a highly sensitive and reliable tool to evaluate retinal neurofunction, and early neuronal dysfunction occurs in diabetic retinopathy which precedes structural changes. And here in this study, we show the evidence of neurodegeneration in the pre-diabetes stage itself. The MLCs were significantly increased in pre-diabetic eyes. The activation of MLCs actually precedes neuronal dysfunction, and this has been clearly shown in some of the neurological studies done in Alzheimer's, etc. Hyperglycemia acts as a tissue stress which causes MLC activation, and continued stress leads to further MLC activation, which is seen in diabetic macular edema and diabetic retinopathy. And here in pre-diabetes also we see the evidence of continued MLC activation. The MLCs were correlated significantly with the MFERG amplitudes, indicating that they are correlated with the severity of the neuronal degeneration. And not only that, they were also correlated with topographically with the MFERG amplitude. So the areas with reduced MFERG amplitudes showed increased MLC numbers. And previous studies in diabetic retinopathy have shown that these areas of reduced MFERG amplitudes, they later on develop the vascular changes about 3 to 5 years later. And here in these pre-diabetic eyes, the MLCs, they not only show the neuronal dysfunction, but they can also probably predict the sites of vascular changes maybe about 15 years later. So the MLCs probably can act as biomarkers for early changes. Sorry. So the limitations of the study, there is one more. There was no significant correlation was seen with the vascular parameters because there was no, So to conclude, this is the first study to evaluate the correlation between MLCs and MFERG in prediabetes. Evidence of early neuronal degeneration is seen in prediabetes with reduced central foveal thickness, reduced MFERG, and increased MLCs. Diabetic retinopathy may be primarily neuronal in origin, and MLCs can act as a non-invasive biomarkers. Thank you.
So this MLC is a latest biomarker in detecting the pre-diabetic.
It can act as a biomarker because it shows a good correlation with neuronal dysfunction, and also it correlates with the MFERG amplitudes, which has been shown to be reduced in diabetics also. So we think that probably the pre-diabetes itself, I mean the changes start much earlier in pre-diabetes. So that is a hypothesis. However, further longitudinal study will be required to confirm this. This is just a pilot study that we did.
Ma'am, any proportional rate of decrease in the amplitudes, or can this be seen as or could be understood like after some years, or how many years before diabetes this would come up in MFERG?
The pre-diabetes itself is like about 3 to 5 years before diabetes you have a stage of pre-diabetes. And so here we are seeing the changes in the pre-diabetes stage. Diabetic retinopathy will develop nearly 10 to 15 years after the patient is diagnosed as diabetes. So before you see the clinically evident changes of diabetic retinopathy like the microaneurysms, etc., we can see this neuronal dysfunction nearly about 10 years before. And actually similar things has been shown in Alzheimer's and Parkinson's also, where the neuronal dysfunction is seen nearly 10 years before the clinically evident signs of neurodegeneration like Parkinson's, etc. So I believe that probably the diabetic retinopathy also is primarily neuronal, and we see this neuronal dysfunction much before diabetic retinopathy. So the stage is set for the diabetic retinopathy changes much before that, before you see the clinically evident signs of diabetic retinopathy. Thank you. Thank you.
We'll have the next speaker, Dr. Swati Padma. You're speaking on a rare case of acute idiopathic blind spot enlargement syndrome.
Good evening, everyone. Today I'm going to discuss about a rare case of acute idiopathic enlarged blind spot syndrome. A 21-year-old female presented with a defective vision in the lateral field of the left eye since 15 days. More specifically, she was telling about a black spot seen in the lateral field, which is associated with photopsia. She gave a history of usage of ATT elsewhere for ocular TB 8 months back. She said she was complaining about floaters at that time, for which her Montuva came positive, and she used ATT for 2 months, and again she stopped because she was intolerant to the medication. There was a history of COVID vaccination 1 month prior to the presentation. Coming to the clinical presentation, visual acuity is 6/6 N6 with -4 spear. She is a moderate myope. The color vision is normal. Intraocular pressure is within normal limits. Anterior segment is unremarkable. Coming to the fundus examination, the fundus is within normal limits except for the optic disc in the peripapillary area. There is a grayish zone seen in the peripapillary area. In the left eye, it is seen even in the right eye, but more specifically in the left eye. The OS disc color image is showing the peripapillary atrophic graying or discoloration seen in the left eye. The IR image showing the atrophied area. The optical coherence tomography image of the OD is within normal limits, whereas in the OS, there is an ellipsoid zone loss seen in the peripapillary area, which is approaching up to the macula. The OS OCT disc image shows there is a outer layer ellipsoid zone loss even seen in the nasal area also. Coming to the visual fields, the Humphrey visual field 30-2, the right eye is within normal limits, whereas the left eye showed enlarged blind spot with a mean deviation of -8.29. So based on, because she is a young myopic female with a monocular blind spot enlargement and the peripapillary outer retinal abnormalities on the OCT, we diagnosed as an acute idiopathic blind spot enlargement. We couldn't do an FFA as the patient was not willing for an invasive procedure. The most common differential diagnoses are the acute zonal occult outer retinopathy and a multiple evanescent white dot syndromes. The treatment for AIBSES remains unclear, but because we thought it might be an inflammatory, we started on a weight-adapted systemic corticosteroids and sent to rheumatologist to rule out autoimmune pathology. Patient followed up after a month, and she said she appreciated the decrease in the size of the scotoma, but was intolerant to steroids and self-stopped. She was lost to follow-up for a year. After a year, she followed up where we have done a repeat OCT, and we could see that this ellipsoid zone got regenerated after a year. This is a OCT disc showing the regeneration of the ellipsoid zone here. We have repeated the OCT, HFA. OS 30-2 visual field shows there is a decrease in the size of the blind spot in the follow-up period with a mean deviation of -3.35. Coming to the conclusion, acute idiopathic blind spot enlargement syndrome is a self-limiting occult peripapillary retinopathy first described by Fletcher et al. It presents either as an isolated finding or as an entity among the spectrum of primary inflammatory choriocapillarypathies with circumscribed loss of the outer retinal function. The etiology still remains unclear. I have already spoken about the differential diagnosis. Actually, Azure and Mutes, they are in close association with acute idiopathic blind spot enlargement syndrome. The spectral domain OCT remains the gold standard for diagnosing this. In our case, we have seen the regeneration of some part of the ellipsoid zone which corresponds to visual improvement. Thank you.
So, what is the main differential diagnosis of this disease?
Acute zonal occult outer retinopathy and multiple evanescent white dot syndromes.
So, only thing is you have to do the follow-up only.
Yes, sir, we have to follow up, and we should have done an FFA in the initial state to rule out, but we couldn't do because the patient was very apprehensive. She was not willing for an invasive procedure.
You mentioned of COVID.
Yes, sir, yes.
Vaccination, so you mentioned about the COVID vaccination. Do you think is there any correlation?
There
Like,
were studies which say that there is a viral prodromal or a viral illness which increases the incidence of acute idiopathic blind spot enlargement. But there should be a complete restoration of the complete vision normal, or the blind spot has to completely reduce if it is because of viral prodrome.
That's what I have studied in one.
Okay, right. Thank you.
Thank
So we'll go to the next speaker, Dr. Shivangi Tirayan. You're speaking on central macular thickness changes after SICS and OCT-based pilot study.
Good evening, sir and ma'am. My topic is central macular thickness changes after SICS and optical coherence tomography based study. So cataract, as we all know, remains one of the leading cause of blindness worldwide, and the cataract surgery is among the most frequently performed surgical procedures. Cataract surgeries are the most common, and the changes in the macular thickness is one of the late complications that may lead to vision deterioration. Pseudophakic CME, known as Irwin gas syndrome, is a complication of cataract removal and IOL implantation. It occurs as the prostaglandins released due to surgical trauma leads to the breakdown of the junctional complexes in the parafoveal region, and the fluid starts accumulating in the intercellular spaces, leading to the formation of cyst. It is often self-limiting. So in our study, we have taken OCT, which is the medical diagnostic imaging technology, from which cross-sectional images of the retina are obtained at the resolution of 10 microns, and we have used it to measure the central macular thickness. The aim of our study is to study the incidence of CME in unevenful cases of SICS, and the objective is to determine changes in macular thickness following unevenful cataract surgery and to elucidate the optical tomographic features of macular thickness after unevenful cataract surgery. It's a hospital-based cross-sectional study with 258 patients, and the inclusion criteria were clinical diagnosis of cataract willing to undergo surgery, any cataract that allows OCT, and unevenful SICS with posterior IOL implantation. These were the exclusion criteria, basically patients with diabetes, hypertension, glaucoma, complications during surgery. We had the methodology. First, we have the preoperative written and informed consent along with BCVA was taken, then followed by IOP, then patency of NLD with slit lamp examination, biomicroscopy, and OCT was done. This was the preoperative OCT macula image. Then peroperatively dilatation was done, then periverbal block, SICS performed with IOL implantation, then duration of the surgery was noted, and absence of any complications was also noted. Post-operatively, we saw the BCVA with slit lamp examination, biomicroscopy, and OCT was done. So this was the OCT of the patient after operation. So the observation that we found that the preoperative mean macular thickness was 217.42 microns. And post-operatively, we saw on first, second, fourth, sixth, and the 12th week. So the first week was 221, then second week was 222, fourth week was 223, sixth week was 226, while on the 12th week, it retained back to 219. So in 258 patients, the subclinical macular edema was seen, and these temporal changes were statistically significant. So basically, the study demonstrated that the SICS is associated with the transient increase in CMT, which peaks at 6 weeks post-operatively and returns to baseline by 12 weeks. The transient increase in CMT was not associated with any clinically significant macular edema or deterioration in visual outcomes, which indicates that routine monitoring is sufficient in uncomplicated cases. And the study also highlights the importance of regular follow-up and OCT monitoring, recognizing the natural course of CMT changes following cataract surgery, which can aid in clinicians in distinguishing normal post-operative findings from early pathological changes which require interventions. Thank you.
So what is the cause of CMT in this SICS?
So basically, since SICS, we are making a tunnel. So prostaglandins are getting released. So these prostaglandins, as there are two ways. So either they break down the blood-retinal barrier, blood-aqueous barrier, and then they cause the inflammation, or they directly enter the posterior chamber, and then they cause the inflammation, which leads to the macular edema.
So this is absolutely a temporary.
Yes, sir, absolutely a temporary thing. But as we know, the Irwin gas syndrome, that leads to deterioration of vision, usually by 2 lines of Snell's chart as per other studies. So that requires our intervention by, we can give flurbiprofen we can give, that decreases the edema in that, if
So
Irwin gas is
only
found.
the medical treatment is sufficient to.
So in the cases we found the macular edema, flurbiprofen was more than enough for the patient to retain the back to 6/6 of the vision.
You mentioned about the OCT monitoring.
Yes.
Later on. So for how long you were monitoring with the OCT?
Sir, we
Was it feasible to do regular OCT with the patients?
Sir, most of the patients, since we only took 258 patients in 18 months, so these were the only patients who came to us for follow-ups for first, second, fourth, sixth, and the 12th week. Otherwise, patients were not coming at the exact interval when we called them, but most of the patients came.
Now, if patient is coming up diminution of vision, then you will go for ECT.
What is the point in going for a OCT where there's not significant change from 217
Okay.
to 219, in between going to 222, double 23 figures? So do you think is that a significant macular edema?
No, that's not significant, sir. That is not significant. Basically, we wanted to see if any significant edema was found in any of the
So
patients.
what did you gather from your study?
Sir, we gathered that we will only one patient out of 258 was found with the clinically significant macular edema. Rest all had no significant edema, but that one patient was also found because we did regular monitoring for the rest of those 258 patients. Otherwise, that one patient would also have been missed.
Not necessarily miss if
If the
patient
vision,
would definitely come down with a decreased
vision. Yeah.
So
But
you can't say it's missed.
yeah.
Dr. Shivangi, all these patients were operated by the same surgeon?
Yes, ma'am.
By the same surgeon.
The same
Anything to
surgeon.
do with the surgical time?
Ma'am, surgical time was noted, but it was not in correlation or it was not statistically significant with any of the edema which was found.
Macular edema can be seen by slit lamp biomicroscopy also.
Yeah.
So what? Maybe that was a thesis topic that was allotted to you?
Yeah,
That's
yes,
it.
ma'am. Yes, ma'am.
But OCT can tell you the exact, madam. If you are seeing with the 90D, it will not give you the exact how much.
Sir, exactly, but a significant macular edema.
Yeah, significant you can notice.
Hardly few
Yeah.
microns, we cannot pick
Yeah,
them up
yeah.
by naked eye. But
yes, ma'am.
basically, all these residents are going for the OCT rather than for the clinical evaluation.
Right.
Just wanted to
Yeah.
emphasize on that point.
Okay, thank you. Thank you very much.
Thank you. We have the next speaker, Dr. Rajeshwari. You'll be speaking on the peeping through the red glow, angioid streaks. Do we have Dr. Tanvi, the last speaker? Absent.
Tanvi is absent.
Okay, thank you.
Good evening, everyone. Now we are talking about the case of angioid streaks. Before going to that, we have to know info about angioid streaks, which are the irregular crack-like dehiscence in the Brooks membrane associated with atrophic degeneration of overlying RPE. It appears as a narrow jagged lines deep to the retina, radiate out in a circinate pattern for peripapillary pigmentation, and these are associated with systemic conditions, most commonly pseudoxanthoma elasticum. And a 43-year-old female patient which attended to her OPD with chief complaints of defective vision in the left eye for the past 4 years and the right eye for the 3 months, and history of floaters since 2 months in both eyes. And the past history, it is a known case of hypertension for the past 2 years and no history of any trauma or head injury. And coming to the ocular examination, the vision of the right eye is 660 with pinhole improved to 612, and the left eye is 1/60, nil improvement in pinhole and glass. The near vision of right eye is +1 spherical. Oblique examination of the right eye shows lids normal, conjunctiva normal, cornea clear, anterior chamber normal depth, iris color pattern normal, and pupil reacting to the light. And the lens changes present. And the left eye shows normal, except the pupil shows RAPD. Color vision of the right eye is normal and the field of vision of right eye is normal. The intraocular pressure measured by the applanation tonometer in sitting position, and patient was not on any anti-glaucoma medication. The right eye shows 20 mm Hg and the left eye shows 16 mm Hg. The fundus examination of the right eye shows media is hazy due to the lens changes, disc was normal, and cup disc ratio is 0.4:1, and vessels was normal. Apart from that, a narrow jagged line deep to the retina was seen, and AV ratio was 2:3, and macula shows a chorioneovascular membrane, and FR shows dull, and background retina shows pre-retinal hemorrhages. And left eye media is hazy due to lens changes, disc was normal and 0.3:1, and here also the vessel shows narrow jagged lines deep to the retina, and AV ratio 2:3, and macula shows scar, and background shows chorioretinal atrophy with scarring. This is the fundus picture of the right eye, which shows chorioneovascular membrane and the angioid streaks, and the left eye shows the angioid streaks and the disciform scar. This is the OCT picture of the right eye and the left eye. This is the FFA finding of the right eye and the left eye, which shows disciform scar. Now our diagnosis is the right eye CNVM with angioid streaks and the left eye macular scar. The discussion of my case was angioid streaks are the distinctive fundus lesions that are associated with systemic disorders in 50% of cases. The most commonly associated disorders include pseudoxanthoma elasticum, Paget's disease, and hemoglobinopathies. Angioid streaks themselves are usually asymptomatic, but the occurrence of CNVM and macular degeneration can cause devastating visual loss. The streaks represent the breaks in the calcified and thickened Brooks membrane, and laser photocoagulation may be the beneficial to treat the CNVM associated with the angioid streaks. However, the recurrence rate is high. Thank you.
So basically, anxiety streak, you have to see for the CNVM also, for the treatment and prognostic point of view.
Yes, sir.
No? Oh.
Thank you.
Okay.
Thank you, sir.
Thank you very much.
Thank you.
Thank you, sir.
Thank you all the speakers for a nice presentation, and you all have answered all the questions of all the judges, and we are all satisfied with your presentation. Thank you very much. Yeah, all. I will respect all the speaker to come in the dais, and we will have a photograph with all.